Hi, everyone. Welcome to this latest installment of Clinician's Brief, the podcast, where we bring you the conversations behind our Clinician's Brief content. I'm your host, Dr. Alyssa Watson, and today I am speaking with Dr. Andrew Linklater. Dr. Linklater is a criticalist at Veterinary Specialists of the Rockies in Castle Rock, Colorado. He's actually been a guest on the podcast previously, although that was before I was hosting, so I'm really excited to sit down with him today. But he's here to share what he believes to be the top 5 causes of pleural effusion in dogs are. So we're going to talk quite a bit about pleural effusion today. And funny enough, the last time he was on the podcast, he was talking about a case about pleural effusion as well. So this is a topic it sounds like you are really interested in, Dr. Linklater.
Absolutely. Yeah. It's a common thing that we'll see, and I love talking about it.
Good. So I'll have to say, I was a big Stephen King fan growing up. And so when I saw, your bio and where you worked, I kind of pictured you in this like reclusive mountain town with all these supernatural things going on. But I'm sure that's not really your life. So if you could take just a minute to tell the audience a little bit about your background, we would love it.
Sure. Yeah. I actually have been to the Stanley Hotel, which is the inspiration for one of Stephen King's movies. Anyway, that was some time before I got here. So I am originally from Canada. That's where I grew up and went through all of my schooling, including vet school. I moved to LA for an internship, and then for the previous 20 years, I've been in Wisconsin, where I did my residency, and then was head of our residency training program, and had us certified as a trauma center and all those sorts of good things. And then was looking for a new adventure. So my wife and I, who is also a veterinarian, just recently moved out to Colorado to experience some of the adventures of the mountains.
Wonderful. Colorado's just beautiful. I've visited there several times. And I also had several husband and wife teams when I was in vet school that were professors and teachers. And I always think that that's so great too. So
Yeah.
let's go ahead and jump in because we have a lot to kind of go over here today. The first thing I want to talk about is these kind of various classification schemes, because it seems to me like there's a lot of different ways to categorize cavitary effusions. And so I was hoping that you would share with us which one you prefer, as well as, I'm a general practitioner. What equipment do I need? What should I be using just point of care at the patient side in order to just get a basic characterization when I have, some sort of cavitary effusion?
Yeah, absolutely. It's kind of an interesting topic, I think, because we're all taught the sort of transudate, modified transudate and exudate in vet school. And so I think it's something that we're all quite familiar with. And in the article, it goes over the criteria that we use. So transudate tends to be that low protein, low cellularity, often clear or only slightly turbid fluid. And switching to the high end, the exudate tends to have a high protein level, generally above 3 grams per deciliter, and a high cell content, again, generally above, I think it's around 7,000 cells per microliter. And then that modified transudate that fits somewhere in between. And I think that's a practical classification. It sort of makes sense. So we're thinking something that is maybe a more active process when we're thinking about an exudate versus a more passive process when we have a transudate. The article does also go over Light's criteria, which has been validated in veterinary patients, but I think just not widely adopted. It requires a little bit more math. So it uses like fluid serum and lactate ratios, a cholesterol level as well, and then a specific gravity. So it's essentially using this very similar criteria to help us differentiate, is this a transudate or exudate? But it just hasn't been as widely adopted. I think practically, as we are in the clinic, I always love to be very practical about everything that we do. I want to make things as easy as possible. And so, tools that you have to have available are pretty simple. Probably a microscope is the most complex tool because it requires us using our eyes and our brains a little bit to look at those things. But then beyond that, it's really just some basic tools. A glucometer can be helpful. Having microhematocrit tubes to measure a PCV in total solids, and then a refractometer to look at protein level, are really the basics. We can do some
Mhm.
additional things like lactate measurements if you happen to have a lactatometer in your hospital. Um, I guess the most complex thing when differentiating these fluids might be measuring cholesterol. So not every hospital is going to have the availability to do that. But with most in-house chemistry machines, it's a simple single test. I know a lot of the current in-house machines can run that, but if you can't run it, you can usually send it out to one of the reference laboratories.
Yeah, exactly. I know we're seeing a little bit of a shift right now in the practices that I work in with using some more artificial intelligence, and some of those scanners to look at cytologies and things like that. But I've been in practice a little over 20 years, and I love my microscope, and so I'm like, no, I really want to look at that ear cytology myself.
Yeah.
So,
Absolutely. Even when we often have our technicians do the preliminary one, but I'm always
mhm,
over at the microscope having a look. And I think, the more you use the microscope, the more you're going to become familiar with it. But it's
mhm.
for a lot of these transudates or a lot of these exudates and cavitary effusions, it's not really that terribly complex. We're often just looking to put it in a category, and then from that category, we can come up with our differential list.
Exactly. So let's talk a little bit about those differentials because obviously this is one of our top five pieces. So we're going to talk about five different causes. I was interested when I read the article about the order that you put them in. Were they in any particular order based on frequency? Because I will tell you, in my experience, there were some things that I'm like, oh, yeah, I see that, a couple times a month. And then there's a couple things on this list that
Yeah.
I've seen maybe once in 20 years. So,
Yeah. Yeah, no, I don't know that they were in any particular order, but I think as I thought through the process of like what is going to be the most common, I of course am going to have a little bit of bias because I'm an
mhm.
emergency doctor, right? So we'll see those things, some things maybe a little bit more frequently, like trauma leading to hemothorax, that sort of thing, that you might not always necessarily see in general practice. But I think when we look at as we go through the individual categories, you'll see that they're certainly the top five things that we're going to think of when we're either having an emergency problem or potentially even a chronic problem. And one of the, I think, more important things to think about is that although we're classifying these fluids into certain categories, just for an example, the hemothorax, which I think is the first one we're going to
Yep.
talk about, there is multiple etiologies or causes of hemothorax, right? We tend to think of coagulopathies and trauma right away, but there's many other things that can cause these. So just because we've categorized the fluid doesn't necessarily mean that we have that underlying etiology or diagnosis that's causing the fluid.
Perfect. So, yes, you are absolutely right. We are going to talk about hemothorax first. And, like you said, for me, this is oftentimes trauma or a coagulopathy, rodenticide poisoning. Although I feel like that's getting less frequent now that I've certainly seen a decrease in the number of anticoagulant rodenticide poisonings that I've seen in practice. And I think that's because, some of those products are no longer sold and available. But I'll tell you, this is kind of that moment where my heart starts racing when I tap the chest or tap the abdomen and I get back frank blood and I
Mhm.
have that heartbeat of like, okay, is this really a hemorrhagic effusion or did I just hit something that I wasn't supposed to, especially in the chest?
Yeah.
So what is the quickest and simplest method to distinguish between, is this truly a hemorrhagic effusion?
Yeah, good question. I think yeah. The first thing we always want to see is when we see that blood come out. Is this truly blood, or is it a blood contaminated fluid? So generally, of course, once the panic sort of settles down a little bit, and we've drawn out some of that fluid, we usually want to take a quick sample of it. and just do a simple, like a hematocrit, a microhematocrit tube to get a PCV level, and then a refractometer reading to get a protein level. And we want to compare that to what the patient's peripheral blood is. So whether it's when we're placing our sample, we can get another, or placing our catheter, sorry, we can get another sample from there, or just do a phlebotomy to get a blood sample. So we want to do a PCV and a total solids on both of those samples. And generally, if it's going to be straight blood, the PCV will fall in within about 5 to 10 percentage points. So if you have a PCV of the blood that's 35, the peripheral fluid is probably going to be somewhere between 30 and 40. And very similar for the protein level. The refractometer reading should be within about 10% of what the blood is. Now, there's always some exceptions to that a little bit, but that's going to give you a pretty good idea that this is blood to start off with.
Okay. And then coming back to all of these different etiologies, is that going to change our prognosis when we have a hemothorax? If we've got a hemothorax caused by trauma, is that going to give us a very vastly different prognosis as to like a coagulation disorder or something, or thrombocytopenia? That's another one I see quite frequently.
Yeah. I think, so let me actually take a step back a second and just mention about the procedure, because you mentioned, oh my goodness, like when you put you do your sterile prep and put the needle in, you want to be cautious that you're not hitting any blood vessels. The chest is a very large space, and usually the vessels that we're concerned about are going to be the ones that are just caudal to the rib. So you want to go on the cranial aspect of the rib as much as possible. And if you do get like a little flash of blood, that's okay. There might be a little skin bleeder or something like that. You really want to look at what is the majority of the fluid that we're pulling out. And as long as they're not coagulopathic, even if you did happen to hit that vessel, it's often not the worst thing in the world. If they're coagulopathic, certainly they're going to develop bruise, and we might exacerbate their bleeding a little bit. But of course, we're going to be treating that at the same time. In terms of prognosis for hemothorax, absolutely, there is a very wide range of prognoses. You mentioned that we're seeing a little bit of reduction of the anticoagulant rodenticides in clinical practice. That's really because the EPA has changed the guidelines for who has access to what. There was some concern about child exposure and some concern about predatory birds getting secondary exposure, which is why these regulations happened. And I think we all felt a little bit on the veterinary side, a little bit unfortunate that now we have to deal with some of those other rodenticides because it can be a little bit harder to treat. Whereas we're often happy when it's an anticoagulant because we have very simple and easy treatment for them.
We know the antidote for that.
Yeah, exactly. It comes with an antidote, right? And it's a simple one. It's just some vitamin K. And if obviously they're hemorrhaging, they might need some blood or some plasma, that sort of thing. So in terms of those prognoses of those different etiologies, yeah, they vary quite a bit. So, we mentioned anticoagulant rodenticides, really common thing, but very easy to treat as long as if they're in shock, we need to give them blood products. That's the most, I think, important thing. If they're having respiratory distress, because we're talking about pleural effusion, we often need to remove that blood, and often we can give it back to them as an autologous blood transfusion. We'll come back to that, I think, in a little bit. So generally for anticoagulant rodenticides, really good prognosis. They are often very treatable, and as long as they survive those first, couple of hours in our care and we can get through the crisis, they do really well. Some of the other etiologies, trauma, well, that's obviously a big concern. It does depend a lot on how significant the trauma was, and there's like scoring systems that are out there that can help us put a prognosis on some of these trauma patients, but often we're dealing with concurrent disease. We didn't really talk about pneumothorax in this particular article because I didn't really think it was an effusion or a fluid, but it is something that we can definitely see with those patients. And again, it probably depends more on their concurrent injuries, not necessarily whether they have a hemothorax. It's often quite minor in a lot of these patients. But they may have things like pulmonary contusions or rib fractures as well. Sure. Some of the other etiologies, they get really interesting at that point. And often we need to do some additional diagnostics. to figure out what's going on, X-rays or CT scan, those types of things. So, neoplasia comes up from time to time. Obviously, the prognosis is not going to be as good with that, but it does depend a little bit on the type of neoplasia. I think the awareness of some of the less common things, but are becoming, we're just more aware of them, like lung lobe torsions. It's
Mhm.
something that we see in pugs from time to time and in other breeds as well. But, that's something that, again, if they survive the acute phases and they're not too severely compromised, they can actually do quite well. But they do need a pretty major surgery to deal with that particular problem. But something that is definitely solvable.
Mhm.
I have seen some quite uncommon things as well, which actually required a CT to diagnose. But I've seen 2 6-year-old dogs with a congenital vascular abnormality in their chest. And they happen to have like a little aneurysm of one of their vessels that ruptured. I was surprised that they had survived to 6 years of age before that was a problem. The prognosis for that, honestly, not good. The surgeons were very anxious about tackling something like that. But the dogs, both of them, stabilized at least for a period of time. I lost them to follow up after about a year, but that's one that's sort of like, ooh, it's a bit of a ticking time bomb. Is this going to be a real problem or not? And there isn't a lot of non-interventional things that we can do. So, putting a prognosis on hemothorax really difficult because it does depend a lot on that underlying etiology.
And then let's talk about that autotransfusion because
Yes.
that was absolutely my next question. So, this is I'm in a practice where I don't have access to, blood products. And so it's a procedure that I've actually never done. It's popped into my mind a couple times and prepped myself for like the things that I would need. So when should a clinician consider that? And yeah, what do you think is kind of like the bare minimum? Am I just, pretty much pulling out 60 cc's of blood and putting it through a filter and shoving it back in an IV?
Oh my goodness. I love this question. This is one of my favorite topics to talk about, and I'm so glad that this came up. So I've published a couple of articles on autologous blood transfusion, and I try and keep up on the literature just to address some of the two really common concerns that come up, more for abdominal blood than
Mhm.
thoracic blood. But if there's contamination or if there's neoplasia present, addressing neoplasia first, there's actually a quite a wide variety of evidence, primarily from human medicine, that has demonstrated that even if neoplasia is present, giving an autologous blood transfusion is quite safe to do. And they have actually even demonstrated like live neoplastic cells in that blood from time to time. But it has not changed in people anyway. Prognosis, rate of metastatic occurrence, or even like long-term outcome. So it really is quite a safe thing to do. Um, I think GI contamination becomes a little bit more concerning, but again, on the human side, because there isn't really published evidence on the veterinary side. So we think about stabbings or gunshot wounds, which can happen, but any blunt or penetrating trauma. Um, there is the possibility of there being GI contamination. And actually, again, those patients, of course, need maybe a little bit longer antibiotics, but the prognosis or the outcome with autologous blood transfusion has actually been pretty good. And I think we're in that situation of um, if the patient's alternative is exsanguination and death, you're well in your medical rights to administer that as a treatment. How to do it? It's actually really simple, and there's a high probability that you have everything in every veterinary practice out there to do this. So basically, we just collect in an aseptic fashion, as we always should be doing, the fluid from the chest, or in some cases, it's the abdomen, into some sort of collection system. And honestly, using an emptied IV bag is probably one of our safest things to do because we know it's sterile and we know that it can contain some fluid. But sometimes we just pull it into a syringe as well. Um, and then we just administer it back IV to the patient. It should always go through a filter of some sort. Humanate filters are pretty common. but they can get clogged pretty quickly, especially for dealing with like a large dog and or large volumes. And so I often will put it in an IV bag because I have IV blood filters available, and you don't need anything special in your hospital. You would have to order those in particular to have them on hand, but you can just give them directly IV back to the patient. You don't have to worry about cross matches or, sort of those acute anaphylactic reactions. They're very unlikely. I would probably run a PCV in total solids, as we talked about already. And if you're a little bit concerned, you can look at that blood under the microscope to make sure. The only time I might hesitate a little bit is if we think the blood might be old, like if it's been in there for more than a day. What I worry about in those cases, and it's difficult information to sort of tease out of the literature, but if the blood has been sitting in that cavity for a while, those neutrophils that are in blood become activated, and they can release a bunch of inflammatory mediators. And if we're infusing those inflammatory mediators, we can lead to like systemic inflammation and all the complications that can come along with that. So that's the only time I'm a little bit hesitant.
Mm-hmm.
But if you're in that situation of you have a dog that got into a rodenticide or a cat that has been traumatized and has a significant hemothorax, it is a relatively safe procedure to do. Obviously, if they have an anticoagulant rodenticide, they're also going to need some vitamin K, going to need some plasma, because generally the blood that we're administering with autologous blood transfusion is devoid of coagulation factors. Usually by the time we get to the point of collecting it from the cavity and giving it back to the patient, it's probably gone through clotting and fibrinolysis. But every once in a while, there are blood clots in there. If there are active blood clots, or we think there's active hemorrhage going on in these patients, I will sometimes add either CPDA or ACD, which is the anticoagulant and preservative that's in blood transfusion. So you can buy just a bag of ACD to have in your hospital. That's really the only additional thing that you might want to have around. Or if you have a blood bank at your hospital, likely you have bags with CPDA already in them, and you can just draw it out of those blood bags and add it. I don't do that very often, actually. The vast majority of the time, I don't add an anticoagulant to the blood. Heparin is an alternative as well.
Yeah. Well, it's good to know that, like you said, at least that there's some data out there showing that overall, it's fairly safe to do it. So, certainly, not wishing any of my patients to have a traumatic hemothorax, but it's, like I said, something I've always kind of wanted to do.
Yeah, it's, as you can see, I could talk about this for a long time. I really like this topic. In fact, I just did an autologous blood transfusion last week. It was for a hemoabdomen. The dog was rolled over by its owner, but it kept the dog alive for a matter of hours while we were kind of deciding, the owners were deciding whether to move forward or not.
Yeah, getting everything else done. Okay.
Yeah.
Well, we're going to need to move on because we've got 5 to get to. So I'm sorry, but we're going to move on to chylothorax. I have seen chylothorax, I think, a couple times. I think it seems to me like both times I've seen it in cats. But, it is kind of one of those that has a typical gross appearance. So could you just describe that to us? What increases your suspicion for a chylothorax right off the bat?
Yeah, absolutely. So, as we all know, the first suspicion is going to be, what does that fluid look like? It's typically a milky white fluid. There might be a little bit of protein in it that gives it a bit of a yellow hue, or sometimes we get a little bit of blood contamination that makes it look like a strawberry milkshake or something like that. But it does have that typical appearance to it. It's actually fairly easy to diagnose chylothorax, but again, we have to look at the underlying etiologies. So the two things that I'm going to run when I see that is paired triglycerides. So I want to know what the fluid triglyceride level is and what the blood triglyceride level is. And basically, if the fluid is 2 times the blood, highly suspicious. That's basically part of the diagnosis of chylothorax. The other thing I might do is look at it under the microscope, which sometimes can get a little bit concerning because quite commonly there's going to be a high lymphocyte count. And often I will involve a pathologist in this review. because we might be concerned maybe in cats, although this article focuses primarily on dogs, but is this lymphoma? And so we do have to often involve a pathologist to help us look at those lymphocytes.
Okay. Yeah.
And there we have our diagnosis. Again, what is that underlying etiology? In cats, we really need to think about heart failure. We don't have a diagnosis of idiopathic chylothorax until we've kind of ruled everything out.
Yep. And there you go again with my next
Yeah.
question. So you're just reading my mind. Yeah.
Yeah.
So that was going to be my next question is the just kind of the proportion or, the percentage of these that are idiopathic, because I know that that does occur in both dogs and cats where we can't find an underlying cause. And
Yep.
then what are the things we're doing to rule out, those other differentials?
Yeah. So we usually want to do a pretty thorough workup. Certainly, taking radiographs after removing the fluid is going to be helpful to identify if there's any masses or maybe lung lobe consolidation, like a torsion, which has been reported as well. In cats, certainly we want to look at their heart. Often I'm recommending an echocardiogram because chylothorax is really common with heart disease in cats. Um, then we get a little bit more complex with our diagnoses. Often we're looking at doing a CT scan to see if there's something that might be a cause, whether there's vascular abnormalities, some other simple things like a heartworm test, which can lead to chylothorax as well. If there is a density that remains in the lungs after removing the fluid, or at least the majority of the fluid that we can see, that's a high suspicious that there is an underlying cause. But out of all of the lists of differentials that are possible, idiopathic is actually quite common. But it is a diagnosis of rule out, right? We have to have looked at some of these more common things to make sure that is not a problem. In part because it really impacts their long-term management. There's both medical and surgical management for chylothorax.
I love that you kind of mentioned how um, the different imaging modalities kind of shift based on whether or not you've tapped this chest. I feel like, when we're dealing with effusion, um, you know, in the chest, ultrasound is really helpful. But then once we drain it, oftentimes radiology, radiographs can be a little bit more helpful in coming to a diagnosis. Do you think that's fair to say?
Yeah, I think so. The X-rays really help us look at the chest in its entirety. Of course, CT is going to be more helpful, but not everyone has that available, right? So ultrasound is really helpful for identifying fluid in the chest, of course. And I think with the advancement and awareness of and availability of ultrasound and POCUS techniques, it's really easy to identify fluid in the chest and then remove it. Once that fluid is gone, if you have a well expanded lung, it's just filled with air, and you can see the borders of the lungs, or maybe if there's a consolidated lung sometimes. But if there's normally inflated lung all the way up to the chest wall, we're going to be pretty limited with what we can see with ultrasound. And then is a good time to say, hey, let's take that X-ray. Now there might be a little bit of residual fluid. We're never going to get all of it out, but hopefully we got a lot of it out. And then we can reevaluate that chest after the fluid has been removed.
Probably makes the patient feel a lot better too.
100%. Yeah, that is that is the number one thing that we're usually trying to achieve with a thoracocentesis is let's relieve that respiratory
Mhm.
distress. Yeah.
Yeah.
Looking to protect your canine patients against parasites? Look no further than Simparica Trio, Serolaner, Moxidectin, and Pyrantel chewable tablets. The first chewable to offer triple protection from heartworm disease, ticks and fleas, and roundworms and hookworms. It's also FDA approved to block infections that may cause Lyme disease by killing deer ticks.
Use with caution in dogs with a history of seizures. Serolaner belongs to the isoxazoline class, which has been associated with neurologic adverse reactions. The most common side effects were vomiting and diarrhea.
Visit SimparicaTrioDVM.com for full prescribing information.
Okay, we're back. Let's jump into the third topic, and that's pyothorax. This one kind of can share some of those same gross characteristics that we were talking about before the break. So I've seen this again in a cat. That's weird. But I've seen this as a milky white fluid. And so when we're looking at these microscopically, what's the big difference?
Yeah, big difference is going to be number one, what is the character of the fluid under the microscope? With a pyothorax, typically we're going to see a lot of neutrophils and sometimes macrophages as well. Depends on maybe that underlying etiology, but they're there to like clean up the mess, right? And then number two, bacteria. They're often present. They're not always easy to identify, though. Sometimes they occur in really small quantities. But if they're present, don't forget to look inside the neutrophils as well. And inside the macrophages, they might be intracellular bacteria. But those are going to be the two biggest changes. Grossly, we may also notice an odor. I actually detest when people go, "Oh, smell this." I'm like, no, I believe you. It's gross. But smelling a fluid, if it has a particular,
Waft it. You have to waft it.
that's right. But if it does have an odor, it's actually a highly suspicious for particularly an anaerobic bacterial infection. So that's something that we might want to investigate as well. So typically we'll send that out for a culture. Again, we need to look at what potential underlying etiologies are. We think of like, a penetrating foreign body or maybe something that was even inhaled, maybe more common in dogs. In cats, we know that often there isn't, and in dogs as well sometimes, but in cats, there's not always an identified etiology. We do think that cats can often develop like little micro abscesses in their lungs if they have really bad underlying inflammatory airway disease. And sometimes those airways just close off. There's a little bit of bacteria in there. You get a little abscess and then it ruptures open into the pleural space. So that's might be a potential etiology, but often we don't find one, even with surgery, even with a CT scan. But they can often be treated medically with antibiotics, draining the effusion out of their chest. Sometimes we do need to place chest tubes to help us lavage out their pleural space.
I'm on the West Coast, so I practice in Vegas. So I blame all of those on migrating grass-awns, those foxtails.
Yeah.
Yep.
Yep.
It's a big foxtail place out here.
Yeah, we have them as well. I just pulled a few out of ears recently, but yeah, they're absolutely in there. Yep. Sometimes we find them, sometimes we don't. But yeah, another good etiology.
When you're looking under the microscope, because we are looking for bacteria and like you said, intracellular bacteria, how are you preparing those slides? Like, are you staining them? Can you just use a
Yeah.
DACVECC stain?
Yep, absolutely. That's usually what I'm using in the hospital. So I prepare it very similar to like a blood smear. So I just put a tiny little drop on a slide and smear it out with another slide as you normally would, and then a DACVECC stain. That's what is most widely available. It's often what clinicians are most comfortable with. And then just looking, I start on the low power and sort of zoom in on the areas where there's a little bit more purple because there's usually a few more cells in there. And then go up to often to oil, especially if we're looking for bacteria. You want to look at those high powers.
Okay. And then you mentioned oftentimes we're sending these out for culture so that we can get, we can identify the bacteria involved as well as get some sensitivity testing, but that takes a while. So what empirical antibiotic choice do you recommend?
Yeah, that's a great question, and I think something that is widely debated. Uh, if you identify bacteria, first of all, is it rod shaped or little cocci? I think that's test number one that helps us make that decision. Number two is if you have gram staining, not all hospitals do, and I would argue that probably most don't, but that might help you as well in that acute setting, can certainly help you make those decisions. Generally, I'm going to be starting with something like Clavamox or the injectable version, which is commonly called Unison. That's the brand name, but ampicillin sulbactam. It's a really broad spectrum antibiotic. It actually covers most of our anaerobes as well. That ampicillin or that aminopenicillin covers a lot of anaerobic bacteria. But with that clavulanic acid, it's also it sort of widens the spectrum to include a lot of those gram negatives.
Mm-hmm.
If you're seeing a lot of rods, I might be inclined to add enrofloxacin as well. If there's a very foul odor, I sometimes will add metronidazole. That sort of rounds out the four quadrants that we commonly think of. but I do tend to be a little bit more conservative with antibiotics. I don't want, resistance to develop. So if the patient is stable and it's just cocci and they're doing pretty well, I'll probably just start with ampicillin sulbactam. It's when I add those things, I need to have a reason for it. So maybe you might have a patient who's septic or neutropenic and you need to be really aggressive right away. Then of course no one's going to fault you for that. But the second part of antibiotic stewardship is when you get those cultures back, de-escalate as quickly as possible. Just they only need to be on the one, or sometimes it's two antibiotics that those bacteria are susceptible. The hard part about pyothorax is it's often multiple bacteria that are involved. So it's common to start with multiple antibiotics, but we do need to de-escalate once we get that culture and sensitivity back.
Yeah, that's interesting. I didn't realize that, usually we're seeing a mixed bacterial population. So, all right, let's move on then from, these pyothoraxes to nonseptic pleural effusions.
Mhm.
This is one that in the article, another one that you mentioned, oftentimes is a good idea to just get a clinical pathologist to take a look at. So why did you feel that way?
Yeah. So oftentimes when the pleural space is sort of agitated or angry, regardless of the underlying pathology, there's these little things called mesothelial cells, which really like to confuse us because they're essentially the lining of the pleural space, the visceral and parietal pleura. And when there is any sort of pathology going on, it's actually quite common for them to get involved in the cleanup process, or for them to just get overexcited about what's going on and shed off into that pleural effusion. And they can look like really nasty neoplastic cells. They're very large. They have huge nuclei. Sometimes they're even dividing. And so you can get those, multinucleate cells sometimes. This is where I have to rely on our pathologists, and in part is because I don't look at a lot of mesotheliomas under microscopy, and I know that they're going to be there. So is it maybe a cancerous cell, or is it just an agitated mesothelial cell that's just kind of doing its job?
Angry.
And differentiating those from neoplastic cells can be really challenging for someone who doesn't look at those often. And then when we get this, sometimes it's a blood tinged fluid, how significant are those white blood cell numbers in there? Is it leaning more towards an infection or leaning more towards cancer? I think it's really important to involve a pathologist, because it's just not something that I do every day, and I want to involve them, before I make a big decision for a client and a pet, especially.
And then how can we set our pathologists up for success? Like what tube
So,
should
yeah.
should we be sending? Do you make a slide in the clinic and send that? Because I know some people feel really strongly that they want a slide prepared right away. And also, what information do you include?
Yeah, I think this is something that I'm sure pathologists would love to speak up at this point about. Providing them as much information as possible is really helpful. And even the post synthesis radiograph information, as much information as you can provide to them. What was the gross nature of the fluid? Where did it come from? How much was it? What were obviously the signalment and clinical signs, that sort of thing. But some of the details about what happened to the patient after we collected the fluid. Did we take those x-rays afterwards? Sometimes they might even request to look at those x-rays. I am generally always going to make a slide. It sort of preserves what those cells look like in the moment, versus just sending the fluid off itself. So they can sort of degenerate and deteriorate, or heaven forbid there's any contamination or something like that of the fluid. It can certainly skew their results. Often pathologists, we do have some more advanced technology now, where some clinics will have an in-house microscope that a pathologist can either collect the images from or read. There's the selfie machine. There's Zoetis
Hmm.
has the Images, those types of
Yep.
things as well. Often they just need a diff quick and send it off. Sometimes they'll want um, like cell counts and refractometer reading or protein level, that's going to help them as well if they're only getting the slides. A lot of the reference laboratories will request, send some fluid and some slides as well. So I'm going to send both if we're sending them out.
And then, just based on your experience, these types of effusions, do they usually yield like a big volume of fluid? Is that, helpful at all diagnostically, compared to some of these other ones? I'm specifically for me, I'm thinking of hydrothorax, where I oftentimes get a huge volume of fluid.
Right. Yeah, typically with our sort of modified transudates, we're often getting a lower volume of fluid because it may be more of a chronic process, or perhaps they have other disease going on, and this is just a secondary complication that's happening. Doesn't mean it can't occur in larger volumes, but quite commonly this is going to be a smaller volume, in which case we may be more doing a diagnostic rather than a therapeutic centesis for these patients. I think you're absolutely right. Chylothorax, hydrothorax, even sometimes hemothorax tends to be a much larger volume. So we do see smaller volumes with this.
Okay. When do you had talked about, especially with something like pyothorax, putting in a chest tube, lavaging that space, get that infection and stuff out of there. So do you ever consider, inserting a chest tube with these cases? Are there particular underlying etiologies that's really helpful with nonseptic effusions as well?
Yeah, that's a great question. With those non-septic effusions, probably less frequently. I'm usually doing a pretty thorough and systemic workup most of the time for those patients to look for why that fluid is there. Chylothorax, hydrothorax, often we're treating the sort of acute problem. It really is more common with pyothorax. We didn't really talk about pneumothorax very much, but if we're having to tap them, multiple times in a day, or needing to do more aggressive interventions like lavaging out the pleural space, or if they have to go to surgery, obviously they're getting a chest tube. That's generally when we're putting them in. A lot of these patients, especially with the non-septic effusions, you collect it to do some diagnostics on it, maybe to relieve an acute problem. But often that might be the end of it while we continue to work up and treat the underlying disease.
Well, that brings us to our last topic. This is the hydrothorax, and
Yeah.
this is the one that I see most frequently. So these are my heart failures, and as well as other things that cause low protein losing, and neuropathies, things like that. And so, what other common causes are there?
Yeah. So whenever I diagnose a hydrothorax, I'm actually going back to my basics from vet school or my residency, where we study Starling's forces. So those are the pressures that are pushing
Oh
fluid
no!
inside the outside of the
I
vessel.
just had
Yeah.
horrible flashbacks.
Oh, no. No good. It's not that difficult. So, we do want to rule out, is there a reason for the fluid to be effusing anywhere? And we look at, systemic or blood protein levels. If they're hypoproteinemic, then we go through our list of, is there protein losing nephropathy, enteropathy, systemic illness, maybe liver failure. There's lots of things that can lower protein. So that's sort of group of differentials number one. Group of differentials number two would be obstruction to blood flow. So they have adequate amounts of blood, normal protein levels, but the blood is not going where it should be. And generally it increases the pressure inside the vessel and it sort of effuses out. We think of cats with heart failure having hydrothorax, but that can happen in dogs as well. We may want to expand our differential list to include really any type of heart disease. So pericardial effusion, potentially. We think of, again, more of ascites, but they can develop a hydrothorax in those instances. Or are they a patient who might be predisposed to blood clots? So maybe they are a cat, again, with heart disease, or have something like immune hemolytic anemia or Cushing's disease, maybe, where that risk might be a little bit higher. Again, it's obstructing blood flow, increasing pressure in some vessels, and that effusion just sort of like oozes out. So we go through that group of differentials as well. And then rarely we're worried about like hypertension. That's not really something that causes hydrothorax primarily. So we're often looking at the those sort of two larger groups of differentials to understand why that fluid is accumulating.
And then there's all sorts of things on that list. So we're obviously not going to go through prognosis and treatment, for each of them. I do have a question though, and with the chest, but also, we've talked a little bit about abdominal effusion and abdominocentesis as well. I have heard varying things over the years about draining large amounts of fluid, from the chest or for the abdomen, and whether or not it's a good idea to do that. Like, should you not drain all of the fluid because there can be, then a massive shift, and cause worsening electrolyte imbalances and things like that. But I don't really know how real that risk is. And so I'm very interested in your opinion.
I would have the same question that you have as well. I don't know how real that risk is, with maybe an exception of a very chronic effusion. So I think when we drain large volumes of fluid, starting with the chest cavity, there is the risk, if it's been a chronically compressed lung. If we drain a lot of that out, there's the potential for re-expansion edema. But we think of that more in our chronic, maybe our diaphragmatic hernia cases, that sort of thing, our congenital abnormalities in cats that we see. That might be more of a risk with those patients. If it's been an acute setting, you're probably fine, and there's a much higher likelihood that the respiratory distress is coming from the compression of the lungs because of that fluid that's in there. And so generally in the chest, we want to take out as much as possible to relieve that respiratory distress. We're not going to get it all, but we want to improve the patient's sort of clinical situation, so we can wean them off of oxygen and that sort of thing. Same concern comes up in the abdomen, but a little bit different. Instead of re-expansion edema, we're worried about sort of relieving the pressure that might be on those large capacitance vessels, and potentially resulting in fluid shifts and hypovolemia. I do worry a little bit about that, but and for me, it just says maybe I should monitor my patient a little bit closer. It doesn't mean that I necessarily mitigate or minimize the amount of fluid that I'm taking out of them. I'll probably watch their blood pressure, because we're removing a high volume of potentially a solute containing fluid. I might monitor their electrolytes. But I've actually had several patients with 10 liters or more in their abdomen, and we removed it without any issue. They didn't become hypotensive or anything like that. If we revisit some of our list of differentials, like a hemothorax, I'm going to be worried about that patient because I know that blood is coming from somewhere, right? So I'll be a little bit more worried about, how much am I getting out here? Am I going to need to give them blood or do an autologous blood transfusion? But in terms of minimizing how much I'm taking out, I generally don't. But I might say, let's monitor our patient. Maybe we watch electrolytes, blood pressure. Maybe we watch their respiratory rate after removing them, which we should probably be doing anyway in most of these patients.
That's very good. Thank you. That makes me feel a lot better. Well, that is the end of your list. And I've just this has been a wonderful conversation. I have learned so much. But before I let you go, there is one more set of questions that we have at the end of our, this is new since the last time you've been on the podcast. So this is a surprise. This is our rapid fire question. This is actually just a little game. The questions are just for fun. They're kind of would you rather questions. Do you want to play with us?
Sure.
Yeah.
Absolutely.
Excellent.
Does rapid fire question mean rapid fire answer?
Yes, you have to answer right off the top of your head. You can't think about it.
Right. Yeah, all right.
All right. Would you rather learn a new skill every year, or would you rather hone one skill and be the best in the whole world at that one thing?
Oh man, I would rather learn a new skill every year. I love to work with my my colleagues, other specialists, other ER doctors, and our GPs who often are doing a lot of follow-up care on the patients that I see. And if I can learn a new skill to get them through a crisis, I want to do that.
Excellent. Lifelong learner. Me too. I love it. Yeah. Okay. If you had to work a relief shift in a really busy ER, do you want to work on a major holiday or would you rather work during a full moon?
Oh man, I'll take I'll take a full moon, I
You'll
think.
take the full
I know
moon, not superstitious at all. Okay.
I know actually there's a study on it. It increases caseload a little bit, but I think I want to spend the holidays with my family, and so the full moon takes it.
Okay. If you were setting up a practice on a desert island, but you could only bring one, would you bring your ultrasound machine or would you bring your x-ray machine?
Wow, these are mean.
I didn't say they were easy questions.
I think I would take my ultrasound machine. I know that I'll regret it at some point, though.
Okay. Last question. This one's the most important. So
Yeah.
if you had a centaur come into your ER that had life-threatening pleural effusion, are you going to tap that horse's thorax first or are you going to tap the man's chest first?
Oh man, where do you come up with this? I suppose I would talk to the man and say, "Are you experiencing respiratory difficulty?" If he says yes, I do the man first, do the horse second.
That seems
Now,
like a well thought out plan.
am I practicing without a human license in that instance? I don't know.
Maybe you should stick to the chest. I have no idea. You could get yourself in trouble with liability.
Yeah, maybe I'll start with the horse then.
You start with the horse.
Yeah.
Well, that was it. I hope you enjoyed it. They were, like I said, just for fun. And thank you again for coming on the podcast. We love having you here. Thanks to our audience for listening. And hopefully we can talk with you again sometime.
I hope so. Love working with these. These are really, with you guys on these. They're really fun, and love working with Clinicians Brief.
Thank you for joining us for today's episode of Clinicians Brief, the podcast. If you enjoyed this episode, you can find us wherever you listen to your favorite podcasts, including a video version on YouTube. While you're there, make sure you subscribe, rate, and review us. You can also listen to or watch our podcast episodes on our website at cliniciansbrief.com/podcasts, or drop us a line at podcasts@vetmedics.com. Clinicians Brief the Podcast is a VetMedics production, produced by Alexis Ussery and hosted by Dr. Alyssa Watson.